Venkat rang me up and said, "Can you do a talk on post-cardiotomy VA ECMO?" And my heart sank because I thought, really, is that the extent of my reputation? It's a bit, it's a bit like when you get asked to do a talk on complications in cardiac surgery. But if for anyone who works in the NHS, you know that you have to be a lead for something. And I was volunteered to be a lead for ECMO in our trust, which is a bad thing. So I've had a little bit of experience. I can't get the into. So just a few declarations. I'm a cardiac surgeon with an interest in the aortic surgery. I have no experience at all of transplant or of ECMO or any such thing. And Liverpool is quite a big cardiac unit. We do over 2,000 cases a year, over 40 ITU beds, 6 theatres, but we're a non-transplant centre. And we also have no experience of ECMO. So I thought, obviously, VV ECMO in the UK, I believe there are 5 centres for VV ECMO. It's quite it's commissioned. There's quite a clear pathway for referral. So we immediately can exclude VV ECMO. In terms of VA ECMO, really, as discussed before, if it's planned VA ECMO post-cardiotomy, then almost certainly it should be referred to a transplant centre beforehand. And we've had one such patient who was transferred to Papworth for that. I'm not going to discuss post-PCI or post-ward arrest, although one of our patients was a ward arrest following cardiac surgery. So it's really about post-cardiotomy VA ECMO. As a bridge to decision making, which it was the case in 2 of our patients who had large strokes, a bridge to recovery in 1 patient, and a bridge to further treatment, which none of our patients have had yet. So this is a summary of some of the outcomes for post-cardiotomy ECMO, which have been discussed briefly in the previous talks. And outcomes are quite variable and not particularly good. And I suppose the only thing to say is the choice is either certain death on the table, or you take a 1 in 5 or 2 in 5 risk of survival. I'm sure anyone in this room would take that chance. One of the registrars who used to work in our unit, Alfred Hinks, sat at the back. He presented this data at the Society last year, and he did a quick survey of units in the UK. And he rang around all the sort of non-ECMO units and tried to get an answer to some questions about these, about whether anyone does post-cardiotomy VA ECMO. And he got a response from 18 units. Mostly he spoke to the chief perfusionist. And of the 18 units he rang, 13 of them did or were using VA ECMO. So not a bad number. And the caseload was a little bit variable. In 2015, there were 17 cases in these 18 units. But half of those units had no cases at all. In the last 10 years, there were 79 cases. Again, 6 units had no cases at all. Just to give you a flavour for what's going on in the UK, because I don't think this data really exists anywhere. Survival to discharge from the base hospital quite low, around 20%, 3 out of 17 patients. And again, in the last 10 years, quite low, less than 20%. Bearing in mind that these are non-transplant centres. About 60% of units had their own ECMO equipment, which is quite good. And certainly in Liverpool, we were the only unit in the northwest up until a few years ago that didn't have an ECMO unit on the shelf. And about 20% of those post-cardiotomy patients were transferred out to transplant units. So in the UK, for those of you who don't work here, the service is uncommissioned, and it's done on an ad hoc basis, and you ring up your local transplant unit, and in our case it's Venkat, and you try and beg, borrow or steal Venkat's very, very kind to us and gives us lots of advice. So in Liverpool, this is one of those things where you come to one of these conferences and usually you boast about you've done 5,000 cases of X, Y, Z. But in this case, I'm proud to say we've only done 5 patients. 4 were post-cardiotomy and 1 was post-award arrest. And of the 4 that we did, 1 was an arch and frozen elephant trunk. And this lady had a problem with a very large right coronary artery aneurysm and some embolization to the distal vessel. And she was the first patient we did. And at that time, we didn't really have the proper equipment. But with Venkat's help, we managed to put her onto VA ECMO. And through frequent telephone calls with him, after about 5 days, we managed to wean her off ECMO, and she went to the ward and she went home. And we thought, this is great. And we used that case as a sort of lever to go out and buy loads of expensive equipment. And we thought all was great. Then the next cases didn't really go that well. So we had a lady who had a root replacement. She had sort of had a subacute type A dissection. She had sickle cell. And we kept the patient warm, but there were all sorts of problems with coming off bypass. And she was put onto VA ECMO, and we actually weaned her off VA ECMO, but she had a large stroke, and eventually a sort of cardiovascular system started to deteriorate, and we felt that it was inappropriate to put her back on ECMO, and she died. And the third patient was a patient who had double valve and ascending, whose right heart got a little bit, was quite coagulopathic at the end of the case, was given a lot of products very quickly. The right heart distended, all mayhem ensued, and never really recovered, and was put onto ECMO, and never really, we were never able to get the patient off ECMO. And then unfortunately a patient, young man who had a straightforward AVR, there were some horrendous technical issues, and the patient was put on ECMO, and was eventually we got the patient to having a closed chest, wasn't bleeding, had woken up and was neurologically intact, and we transferred the patient to Papworth. Unfortunately, he subsequently died of bowel problems. So the median age, 42 young patients, and a total of 23 days on ECMO, which I'll come back to, which really creates mayhem in a non-ECMO unit. So these I've already discussed, I'll skip through that. But the issues that these cases raised for us really were impact on routine service. For those of you who work in transplant units or ECMO units, I'm sure you won't think twice about putting a patient on ECMO. If you work in a non-ECMO centre, it creates all sorts of trouble. The system has to be run by perfusionists, and they want 2 of them rotating, so 4 over 24 hours. Usually have 2 or 3 nurses. And the first one we did, the hospital basically came to virtual stop. Yeah, that created a lot of issues. We've got better as we've done more and more, and it has less and less of an impact. But again, if you're not doing them regularly, you don't have access to ECMO nurses, so it's very difficult on the perfusion department. It's very expensive, it's unfunded, and you're vulnerable to comments by other surgeons. This single patient has cost us 18 pumps, and those sorts of comparisons, which are difficult to justify or argue with. They created issues around selection of ECMO. As you can imagine, we were concerned that surgeons were going to put the patient on VA ECMO at the drop of a hat. So really, after discussion with Venkat and looking at transplant sort of criteria, we sort of adopted a protocol as Venkat's discussed, and we have this sort of little ECMO council where the clinical lead for surgery, the clinical lead for intensive care, and the surgeon involved, they get together and have a chat, see what they think should be done, and then we ring up Venkat. If Venkat says, yeah, it's a good idea, or it's a bad idea, then we'll put the patient on ECMO if he says it's a good idea. Who should manage the ECMO is a problem. Really, we discussed earlier really whether the patient should be retrieved from the table by an ECMO unit, which is really, I think, unrealistic. You need to have a system or an ECMO unit in your hospital, get the patient off the table, onto the unit, stable, not bleeding, closed chest, and then hopefully the patient can be taken away. And there are all sorts of governance issues, as you can imagine, because we're a non-ECMO, non-transplant unit, and managers were concerned about litigation, things like that. Of course, that's with and without ECMO. So this is a picture of the first patient we did, the lady, and this is the one that went home, and then she sent this picture to us, and you can imagine it's a great picture to show to the managers, to say, can you give us a whole pile of cash to go out and buy some machines? And they love that sort of thing, patient stories, and they gave us a whole pile of cash. So what would I like for my hospital and my patients? I'd like to give appropriate patients the opportunity, and I think there should be really strong governance in who is put on VA ECMO, and that should be really led by a local transplant centre. If Venkat says no, it's very difficult for us to go ahead and put the patient on ECMO. There should be tight standard operating protocols for people who are looking after these patients who are not familiar with ECMO, strong links to transplant units. And for Venkat, my only one small criticism of Venkat is his online form, which is long and difficult, but usually we bypass that because I have his mobile number, so I'll ring him up directly and bypass the ECMO coordinator. Transfers as soon as possible, accepting that we really have a very rudimentary understanding of what we're doing, and equity of access for all patients. And what we don't want to do is insidiously develop a non-commissioned ECMO service, and really don't want to negatively impact other patients in our hospital who are coming in for routine surgery, and we don't want to use it inappropriately. One thing that's crossed our minds is really patient and family expectations. There will come a time when patients or their relatives certainly may ask, and sort of there may be litigation around the fact that you're doing this complex heart operation, but you're unable to provide ECMO support after the operation. And so I'm sure it's inevitable that the litigation problems will come. So yes, I do think that every unit should have MCS, but national guidelines I think would be very helpful, so there's no ambiguity from centre to centre. Strict local governance links to ECMO centres, and transfer to the local centre providing no bleeding, the chest is closed and neurologically intact. Health economics I have no idea about. We put TAVIs in 80 and 90-year-olds without thinking too much about, but then we complain about this young lady going back home to her 3 children. So I'm not really sure how we get around that, whether we can afford both or neither or one or the other. It's very difficult. Thank you.